Hi, everyone. This is Kathy Bush, and welcome to the DandleLION Medical webinar titled Supporting Mothers and Newborns Through Transitional Neonatal Hypoglycemia. Our faculty presenter this morning is Catherine Bennett. Catherine has worked in OB for the last 40 years as a childbirth educator, doula, and special care staff nurse. She is currently the perinatal clinical nurse specialist at Advocate General Lutheran Hospital in Park Ridge, Illinois. She and her team implemented the use of glucose gel in their level 3 teaching hospital 5 years ago, and they found that they were able to reduce the use of IV dextrose in NICU admissions by over 75%. She has published several studies on the use of glucose and has also spoken at many national conferences on the topic. So we're thrilled to have you this morning, Catherine. Thank you so much, and ready to hear your great information.
Oh, well, I'm really happy to be here, and thanks all for tuning in. We are going to be talking about neonatal hypoglycemia, which is a hot topic these days and has been for the last 40 years. And it still has more questions than answers, but I will try to go through what I believe to be true about neonatal hypoglycemia. So here are the objectives for today: to describe the physiologic glycemic transition from fetus to newborn, and then the role of glucose gel in supporting these babies. I do not have any disclosures or conflicts of interest to report. So you probably, if you work with babies and moms, you probably know that neonatal hypoglycemia is the metabolic condition that is most responsible for infant admissions to NICUs. And it's associated with perinatal stress, preterm births, gestational diabetes, and preeclampsia. And as we've had an increase in hypertension and an increase in maternal gestational diabetes and obesity, we've seen more and more. At our hospital, we have about 20 to 25% of our infants are affected by one of these risk factors. So the risk factors that we use at our hospital, and this is pretty typical throughout, if you look throughout the literature and throughout other hospitals, is large for gestational age, small for gestational age, late preterm infants, infants of diabetic mothers. If they're symptomatic, these are the infants that we test, and APGAR is less than 7 at 5 minutes, and any infant requiring resuscitation. So in the fall of 2013, we were thinking we had a lot of babies that were transferring from the mother baby unit to NICU. And as we did an audit on that, we found that the #1 indication for transfer was neonatal hypoglycemia. So we were putting our heads together trying to think what types of interventions can we perform to intervene and to try to reduce this number. And one of our nurses saw this research study that was published in the Lancet, dextrose gel for neonatal hypoglycemia, done in New Zealand, and it was conducted in 2010. So we brought this article to our newborn advisory committee, which is a group of neonatologists, directors, nurse managers, and APNs, and also staff nurses. So this study was as I said, conducted in New Zealand. They gave infants dextrose gel rather than IV dextrose, and it was a randomized controlled study, and there were infants that received dextrose or glucose gel, which I'll use interchangeably here because they're exactly the same, and a placebo. And the ones receiving the glucose gel were much more likely to be admitted to NICU for hypoglycemia, much less likely to receive IV dextrose, and less likely to have any episodes of recurrent hypoglycemia, and less likely to require any supplementation. So we brought this to our multidisciplinary committee, and we were very fortunate in having a very forward-thinking neonatologist who said, hey, let's try this. So it wasn't quite so easy and as just saying that, but we did implement it about 8 months later. And after we had such great results, we actually wrote an article, and this is the article that we wrote, which talks about how to implement a nursing, this protocol, a nurse-driven protocol. We give glucose gel to asymptomatic infants, and our transfers decreased by 75%, and our exclusive breastfeeding rates increased by 50%. So that is in Nursing for Women's Health, and the references are at the end, and you can look into that later. At the same time that we were doing our intervention, there was an actual study, a retrospective study done out of the Women's and Children's Hospital in Buffalo, and their results, when I read their paper, it was almost exactly the same as ours. And they had 248 infants in the pre-implementation group and 250 in the post, and they also found that the transfer to NICUs for IV dextrose was decreased by about 70%. Their inclusion criteria was asymptomatic infants greater than 35 weeks gestation with blood glucose levels less than 45 milligrams per deciliter. These infants were given just a maximum of 3 doses of the dextrose gel along with feeds. We'll talk about protocols in a little bit. So they lowered their incidence of transfers, and they lowered the incidence of needing IV dextrose, increased exclusive breastfeeding, and of course there was less separation from their moms. This is a recent study done in 2017. This is actually a colleague of mine, and she's within our hospital system, and she wanted to look at how this worked in a level 2 hospital. So they implemented a toolkit, and they found a 6.5% increase in exclusive breastfeeding and a 5% decrease in admissions to intermediate care nursery. So their numbers weren't as stellar as ours for the intermediate, for the needing of IV glucose, but they were really looking at increasing their exclusive breastfeeding rates. All right, so how much of a problem is neonatal hypoglycemia? It occurs in up to 20% of newborns. And here's one of the big problems. There's no agreement among experts as to what the threshold, what the number should be for normal or safe blood glucose levels during the first 24 or 48 hours of life. Here's a little physiology with that. The fetus receives a steady stream of glucose from his or her mother via facilitated diffusion across the placenta. And then the fetus, produces its own insulin to reach euglycemia. Once removed from the glucose source, the mother, the infant may have higher insulin levels compared to the amount of glucose available. So the fetal norm is about 50 milligrams per deciliter. And the low ranges for neonatal life are between 20 and 50 milligrams during the first 2 hours of life. So in nature, you always have to ask, is there a reason for this? And with the low glucose levels, it does stimulate an infant's appetite. These low glucose levels are observed in all mammals, and so may be an evolutionary adaptation to early life. So during fetal life, the fetus is not producing its own glucose, so once born, the process needs to get a jump start to succeed at postnatal life. The low glucose levels promote gluconeogenesis, which is the production of glucose from amino acids and fats, and glycogenolysis, which is an increase in the blood glucose. It stimulates the liver to break down glycogen that's stored in the muscles and liver and release glucose back into the bloodstream. So if they didn't have these low levels of glucose, they might not jumpstart all these things that we need for an adaptation to life. It was recognized that hypoglycemia can at times be pathologic. So the NICHD, Eunice Kennedy Shriver National Institute of Child Health and Human Development, convened an expert panel in 2008. And their findings, oh man, no true definition of neonatal hypoglycemia. And so they called for a group of experts to look into what levels would be safe, which still has not been established, and this is now 11 years later. But in order to address that, the AAP, I'm sure many of you are familiar with this, the AAP did establish a protocol that is not necessarily evidence-based, but it was their pragmatic approach to dealing with glucose levels. I'm not going to go through this step by step because it's not currently it doesn't include glucose gel, but these kind of steps of looking at what an asymptomatic, what to their expert opinions were okay for an asymptomatic newborn in the first 24 hours of life. So how low is too low for glucose? There's been many case studies over the years. In 2009, Hay looked at infants who were healthy breastfed infants and found levels as low as 23 milligrams per deciliter. And then David Adamkin is he wrote up the expert opinion for the AAP. He talks about that 30 milligrams per deciliter is very common in healthy infants during the initial 1 to 2 hours of life. And when we hear about neurologic damage for neonates associated with hypoglycemia, it's always associated with levels that were sustained at less than 10 for more than 10 hours. So these are case studies that have been done that show when they backtrack of babies that have issues from hypoglycemia, it's very low levels for a very long time. So there's been many, many meetings, the Pediatric, can't remember, well, the Pediatric Endocrine Society and the AAP have kind of been a little bit at odds with what they recommend in terms of values for neonatal hypoglycemia. And in each of these boxes, I'm going to read through this because it's kind of important. The AAP values are derived from a range of values seen in healthy newborns. And the range can start as low as 20 to 25 and go up to like 75, 80 milligrams per deciliter. The numbers that the Pediatric Endocrine Society uses are the mean. So they're taking the average of this 20 to 70 and come up with figures around 55 to 65 milligrams per deciliter at birth, and then increase to over 70 by 2 to 3 days. So the problem with using really high numbers in the beginning, in the first couple hours of life, when there is a natural mammal tendency to have really low glucose levels, really can cause overscreening. So overscreening and overdiagnosing and overtreating are the concerns if you use such a limit, if you set this lower limit at 50 or 55 or 65. Part of the concern from the Pediatric Endocrine Society is that neonatal hypoglycemia mimics congenital hyperinsulinism. So the thing with that is that these infants that have this, it's very low incidence, 1 in 50,000, and these babies keep putting out more insulin, higher levels of insulin than are needed for the amount of glucose that they have, which is exactly what's happening in the beginning of the baby's life, because it's putting out too much insulin for the amount of glucose that they themselves are producing at that moment because they've been used to the maternal glucose levels. So they have to get up to speed of creating their own glucose levels to meet up with and then the insulin needs to regulate in order to match up with that. So that takes a few hours of life. So the congenital hyperinsulinism really doesn't happen until you cannot really diagnose this till after 48 hours of age. So this is outside of the time that we're talking about and that the babies are even in the hospital with us. So what is the problem of overtreating? We know that there's iatrogenic harm from increased intervention. It certainly decreases breastfeeding because often the solution is to give formula. And then also the little heel sticks over and over again, it can alter the cortical development from pain-induced stress with all the heel lancing. There's a number out there, 47 milligrams per deciliter, which I'm sure you're all familiar with. And that seems to be a number that keeps coming up. Well, where did this number come from? In 1988, there was a study that reported impaired motor and cognitive development at 18 months of age for infants that were born weighing less than 1,850 grams at birth and had recurrent asymptomatic hypoglycemia, less than 47 for more than 3 days. Well, we can't take a study that was done on infants born at 1,850 grams and generalize that to the general population. And in fact, a quote from that particular article states the association between modest hypoglycemia and poor neurodevelopment reported here might not be causal and might reflect our failure to adjust for confounding factors. And I think that you can see that we can't really use this number as the number that we look for in the first hour of life from this study, but it is often referred to. Here's some quotes from the Journal of Pediatrics just a couple years ago supporting the use of glucose gel. Dextrose gel, glucose gel, and breastfeeding should be considered for first-line oral treatment of infants with hypoglycemia. And in the same article, 40% dextrose gel offers an alternative to formula that actually improves breastfeeding rates at 2 weeks of age and reduces admission to the NICU for treatment of hypoglycemia with IV dextrose. So both of these statements were published in the Journal of Pediatrics. Now you might, if people are looking at arguments against using the AAP numbers and against using glucose gel, one of the studies that sometimes comes up is this study done by Kaiser. It's called the Association Between Transient Newborn Hypoglycemia and Fourth Grade Achievement Test Proficiency. And I just bring this up because when it comes up, sometimes people put a lot of stake in this, and I just want to point out a couple of the issues with this. So Kaiser controlled for gestational age, race, sex, multifetal gestation, insurance status, education level, and socioeconomic status. And okay, so this study, it is really facility-based rather than population-based. There was a response to this by a PhD, not a physician, but a PhD scientist. This study is facility-based rather than population-based. 81.5% of the families had Medicaid or no insurance. 74.8% of the mothers had an education below high school. And the incidence in this group of preterm labor was as high as 31%. So both preterm labor and poor economic conditions are also closely related to neonatal hypoglycemia and school performance. In this study, it does not talk about what interventions these received. So we don't know if they received formula. In this study, what they did is at that time in Alabama, they did an AccuCheck on every baby within the first couple hours of life. And then they have that data on all the babies that were in the study. And then they look at test scores at 10 years of age. Well, there's a lot that can happen between 2 hours of life and 10 years of age. And one thing that they didn't talk about is in the early days of that baby, were they receiving formula? Were they getting IVs? Did they have NICU admissions? So these are all variables that can certainly affect test scores of infants at 10 years of age. We know how important bonding and non-separation of mother and infants are. There's a lot of studies that have shown that, and so there's no way to determine if the results of his study were because of the interventions that occurred and the separation of moms and babies at that time. There also is the group that did the research in New Zealand have been looking at the same group of babies for the last 4.5 years. And their conclusions are that neonatal hypoglycemia was not associated with increased risk of neurosensory impairment, but it was associated with poor executive function and visual motor function. So actually, when they've looked at these, this study is out there, but when they have looked at these infants farther along, they actually have joined, the difference is not evident. But that study has actually not been published, but I do know these people, and so we've talked about that. But the authors state that the highest risk in all of these children were to those that were severe recurrent hypoglycemia. And also, there were infants that were included in this study. This was a combination of the original Harris study, and then there were other babies that had been studied also. And some of the infants in this group were 32 weeks gestation and above, and some had acute illness. So when we're looking at, again, at the anything that's happening out in the future, and you are including babies that might, whether or not hypoglycemic, have other issues from being sick or being very preterm, having NICU admissions or IVs or formula feeding, we cannot discount what kind of effect that has on the infant. So in all of these, really the critical point is that is the infant symptomatic or is the infant not symptomatic? Any infant with clinical signs should be screened and treated immediately. So here's a list of some of the clinical signs that define symptomatic. Jittery, cyanosis, seizures, apneic, tachypneic, weak or high-pitched cry, floppy or lethargic, poor feeding, and eye rolling. So if you, any nurse that I know that sees a baby with these symptoms want to immediately do a glucose check, as they should. And if the babies are symptomatic and they have low blood glucose levels, a dose of dextrose gel or glucose gel is fine, but they need to be observed very closely and their treatment discussed with the physician. I just want to show you the progress that we made in 2013. You see that we have a high percentage of infants that were transferred to NICU. So these are, the percentage is the number of babies that were on the protocol, the number of babies that are at risk, and the percentage of those that went to NICU. So of the babies that were at risk in 2013, we had about 11% of the infants were being transferred to NICU. It's not 11% of all of our babies, just the ones that are at risk. And then we started the protocol in the middle of 2014, and you can see we already had a decrease to about 3. And then in 2015, we had a really good year of 2%. And then we've continued on with a very much lower percentage than the 11% that we started with. Now, the differences in these months or the years is sometimes 1 or 2 babies. So if we, in real numbers these days, what we have is sometimes 2 or 3 babies that are transferred in a month. And we have about 350 deliveries a month. So we've really decreased the number. We were doing so well at our site that we decided we're in a hospital system of 10 hospitals. And now we've actually joined forces with another hospital system, so now we even have more than that. But in 2017, there was a group of neonatologists, pediatricians, and APNs that got together to standardize the protocol, because some of my colleagues at some of our other sites had started doing gel, but everybody had a little bit different thing that they were doing. And at Advocate, we like to standardize our protocols so that any infant that's cared for at any of our hospitals has a benefit of the best treatment. So we share our information among each other. And I have to say, I've shared this information across the United States over the last, since 2014, and a lot of people are doing glucose gel. So we got together with this work group, and we implemented the practice of using 40% glucose gel as the first line of treatment for asymptomatic infants on March 8th of 2017. The work group got together, and I'm going to show you. This is what the work group came up with as an algorithm. It's not at all what my original algorithm looked like, but with collaboration comes compromise, and I've learned to love it. So this is what we do, and you can look at the numbers on your own. But briefly, we follow part of the AAP guidelines, which is that the infant is put to breast and is supposed to feed within the first 60 minutes of birth, and then 30 minutes after that feed is completed, we do a blood glucose. If it's greater than 35, great, then we just continue on with the feeds every 2 to 3 hours and do pre-feed blood glucose screens. If it's less than 35, the nurse administers glucose gel. So OGG is oral glucose gel. And the infant is placed skin to skin and to feed. So this is a really important part of glucose gel, is that you need glucose gel along with breast milk. Or if the patient is formula feeding, then like a few millimeters, 10 millimeters, 15 milliliters of formula. You don't want to overfeed these babies either. So after they get the glucose gel, then we do the blood glucose again after an hour, and then this follows along. But our target is that within the first 4 hours, the infant has a blood glucose level of over 35 milligrams per deciliter, and in the first 24 hours, over 45. And then if we should happen to get into a situation where an infant becomes symptomatic after the first 24 hours of life, then we're looking for a target rate of over 50. Now, I'm going to show you this video, and you'll be able to access it yourself on my Facebook page. And this is a video of me giving glucose gel to a simulator baby.
I'm going to demonstrate how to properly administer glucose gel. First, gather your supplies, the glucose gel, an oral syringe, and sterile 2x2s. The first thing you'll do is take one of the 2x2s and wipe out the buccal cavity of the infant, just to dry that buccal cavity slightly. One side and then the other side. Then fill the syringe. In this case, let's say the baby is 4 kilos, so you will be giving 2 mLs of the gel. You can just squish this in the back of the syringe and then waste it until you get the proper amount. So bubbles, and then you want to try to get the bubbles out if you can, and go down to 2 mLs. Now you're going to take a portion of that, about a quarter, put it on your finger, and then massage in the buccal cavities. In this case, this baby cannot receive the gel, so I'll just dry off my finger, and I'm going to massage. Give a little bit more of the dosing, massage, the other side, massage until the gel is all gone. Once that's complete, you want to pick up the baby and take the baby right to the mother so that she can breastfeed. Thank you.
Okay, so that is the proper way to administer glucose gel. Here's the data in real numbers. So just to look at 2018, there were 826 infants that were at risk. So they had one of those risk factors that we mentioned earlier. There were 278 who received gel, and there were 33 for the whole year that went to NICU. So that is the percentage of 4.01%. And our grand total, you can see in the very right-hand column that we have given gel to 1,315 babies, and we've had no negative response either during the administration, after the administration, or over the last couple of years. There's never been any reports of any problems with the gel. This is an algorithm that has been developed by PICNIC, which is the Perinatal Quality Collaborative of North Carolina. I was very pleased to go to visit with and present to their perinatal collaborative last year, and had been on a work group with them for the year preceding that. And they developed this algorithm, which is pretty similar to ours. They actually have some different numbers, as you can see. So this is one thing that's kind of interesting and also a little problematic for people, is that there are so many different numbers of target ranges out there because of the discrepancy. There's really no proof. There's no evidence that shows what is the adequate number for to reduce any kind of potential of issues for infants with hypoglycemia. But we can pretty much all agree that as long as we keep the infants around 40 or 45, that should be after that, once they've reached 4 hours of age, having the infants be at least 45 milligrams per deciliter up until 24 hours, that's pretty well agreed upon. All right, so as we rolled this out in our advocate system, we had really good success. There was less separation and more togetherness with the moms and babies. Whoopsie. And as a bonus, the financial gurus estimated that we had an annual savings of about $3 million in healthcare dollars. So it kind of depends how you get paid, but we get paid. Our reimbursement is global, so anyway, we want to save the money, and also you don't want to have a baby in NICU that doesn't need to be there. So here's things that are really important reminders about glucose gel. Once the gel is administered, the infant should be placed skin to skin and encouraged to breastfeed. Skin to skin supports increased glucose levels, thermoregulation, and decreases the physiologic stress response. And an AC bedside glucose should not be obtained sooner than 2 hours after the normal level. The reason this is in here is that when we say you're going to do a bedside glucose before the next feed, if an infant is cluster feeding every hour or every hour and a half, you don't want to keep doing, you would want to skip 1 or 2 of those feedings so that you could get at least 2 hours between the glucose levels. And it's really important to look at the big picture when assessing the need to administer glucose or continue with glucose checks. So what's next on the horizon? There's been also the group from New Zealand has just completed a randomized controlled study, and their results are not published yet. But what they're looking at is, since we know that there can be problems for infants who, it's hard for infants to catch up to a good level of glucose in their bloodstream, that what if we were to give oral glucose or dextrose gel to newborn babies who are at risk in the first hour of life before we did a glucose check? Would that change their numbers? And I'm going to play a video of one of the researchers from New Zealand, I think. All right. It's just interesting to see, and they also do a sample of showing the baby getting the glucose gel.
The research team at the Liggins Institute have been interested in caring for babies with low blood glucoses for a long time. Low blood sugar levels are common in newborn babies, and if they're bad enough, can actually cause brain damage. We know that some babies are at risk of having low blood sugars, and generally the only effective approach is admission to an intensive care unit, putting up a drip, separating the baby from its family. It's expensive, it's unhappy for the baby and the family. We were keen to try and find a better, simpler way of treating this common problem. We found that you can put sugar in a very high concentration gel, and what we do is rub that inside the baby's cheek.
Got some millions for you.
That means it gets absorbed across the inside of the cheek, puts the blood sugar up very quickly. What we found in that study was that the babies who received the sugar gel were about half as likely to need some other kind of treatment for their low blood sugar levels. The exciting thing about the dextrose gel is that it is simple and safe, and it works to improve babies' blood glucose levels. So we thought, if it works well to treat babies with low blood sugar, could we use it to prevent babies getting low blood sugars? So the new study is called HPOD, Hypoglycemia Prevention with Oral Dextrose. We're looking at preventing hypoglycemia, low blood sugar levels, by giving the gel to babies early before they get low sugars. For HPOD, we're looking at about 2,200 babies. This is a very big study. It means we're going to need to do it in a number of hospitals around New Zealand, and we need a lot of help to do that for a lot of babies.
My name's Jenny Rogers. Nice to meet you.
I'm Jenny.
If mothers are interested in taking part, they need to sign the consent form and make sure that we know when the baby's born so that the baby can get the treatment at the right time.
My midwife told me that because I have gestational diabetes, my baby will be at risk of low blood sugars, but I'm not sure why that's important.
That's important because if a newborn baby experiences a low blood sugar, it could actually affect their ongoing brain development.
We're asking mothers to take part in the trial if they are likely to have a baby who is known to be at risk of having low blood sugars. That means mothers who have any kind of diabetes, mothers who are likely to have a baby who is either smaller or larger than average, or mothers who are likely to have a baby who is late preterm, so 35, 36 weeks gestation.
If I do decide to take part, what will happen?
We would check soon after baby's born as to whether baby is eligible or not to take part in the study. And at 1 hour of age, a gel will be rubbed inside the baby's inner cheek.
Most babies will already be feeding at that point. It's not meant to interfere with feeding, it's just in addition to breastfeeding at that time.
Because this is a randomised trial, the computer actually decides which gel your baby receives. It could either be a dextrose gel or it could be a placebo gel, which is a gel that does not contain sugar.
Are there any risks to my baby?
No, dextrose gel is already used to treat babies. It's already a proven safe treatment. Then after giving the gel, all other care for your baby will be exactly the same as it would be for any baby.
After the birth, she was given a gel into her mouth.
It's a little bit of a blur, but I do remember he was lying on my chest and they gave him some gel.
They would just put a little bit on the gel on their finger and just rub it into his gums. He was completely happy with it.
It was a rather easy, non-complicated experience.
We're hoping that what this trial will show us is that receiving a dose of dextrose gel soon after birth prevents low blood sugar levels. In the long term, we would hope that that would prevent brain damage, that would improve the outcome for development and learning of these children.
I'm glad we did it, and my advice for any other mother would be to use HPOD. It's been great for us.
A lot of people probably wouldn't think that it's that important, but it could make a big difference.
We're really lucky. Charlie is a little IVF baby, and so we only have him thanks to the advantages of medicine and really what's being done through some of these studies. So anything that we can give back and help out with Definitely.
At the moment, as many as a third of all babies are born at risk, but the number of women with diabetes and the number of women having preterm or large babies is growing steadily, so that it's a large number of families who might benefit from this treatment. If this is a successful treatment, we expect that it would be used in most parts of the world. This treatment, we think, will really revolutionise the way babies are managed around the world, and that's millions of families who will be better off as a result of this treatment.
Okay, so I hope you enjoyed that. A lot of cute babies in that. And this is significant research, and the results will be coming out sometime soon. There was a group that, oh no, wait. Okay, are we okay? There was a group that wanted to do a study similar to what the researchers in New Zealand were doing. So they set about to do prophylactic dextrose gel. And so you can see from the title that their study did not work out in the same way that the trial did in New Zealand. So they wanted to, and I spoke with these people as they were setting up their hypothesis and their program, and I know that they spoke with the people in New Zealand before they did their study. But one thing happened that is different from what the dextrose gel that we use, and that is that they used a 77% glucose gel rather than the 40% glucose gel, or dextrose gel, which has been used in all the other studies. So they were wanting to test the hypothesis that if they gave dextrose gel to newborn infants at risk, will it increase the initial blood glucose concentration? And they found that it didn't. Although they reported that it went from 9.7 to 14.7 with the control. So it looks to me like there is that there was some decrease, but they did not have the results that they expected to have. But one of the things that's really important about that study, as I said, is that they used a different concentration of glucose gel. So this is also something, I'm bringing up these things just because some of these studies sometimes become barriers when you're trying to implement in your settings. And it's important to have the information of, well, okay, this is not exactly what we're talking about, because we what the dextrose gel that we use is 40%. So last year, I was out on medical leave, and so I played around with SurveyMonkey, and I went through all of my emails for over the last 3 or 4 years of people who had asked me information about our implementation of our program. So I sent SurveyMonkey to each of those, and I got really a great response. And so of all the 150 people that I sent this to, I got about 125 responses. And respondents also identified 145 other sites that had implemented. So from our beginning in 2014 until now, there's so many places that have started using glucose gel. So I just want to show you these slides they implemented. There was 80% of the people who I had emailed, and a large percentage, where 72% were seeing a decrease in the need for IV dextrose. So this, as far as I know, in 2014, there were 2 centers that were using, in the United States, using glucose gel. And that was, I mentioned the study out of the Women's and Children's Hospital in Buffalo, and then also in our hospital. So as the years went, 2015, there were no hospitals that I could see, but in 2016, 2017, and 2018. And I know that over in California, all the way over on the left-hand side there, that Kaiser Hospital has implemented in 14 sites over the last couple of years. So this is just the people that had been influenced by or had started after they had either heard me speak at A1 or read the article or that had emailed me. So this is just only the people that I know. So I know that this is sort of becoming ubiquitous and becoming almost a new standard of care. And as we go through thinking about glucose gel, the main point is that we really want to keep the new family together whenever possible. So an infant who's not really sick and who just has transitional neonatal hypoglycemia can often be very well treated using 40% glucose gel, and that's it. So I have placed a lot of references in this slideshow, which you'll be able to access, and I am open to any questions that you have.
Catherine, that was really great. Thank you so much. Lots of great information in there. And as she stated, when we send you out the link for the recording, we will also include the PowerPoint presentation, and you'll be able to have all the references, and someone else wanted some of the things that she showed, and you'll be able to see them all there. So right now we want to open up to some questions. So if you run your cursor over the bottom of the Zoom screen, you'll see a Q&A box. We've already got a few people waiting. And Kathy Randall is going to help us out with the questions and feeding the questions to Catherine, and we'll let you ask as many as you need to. So Kathy, you want to start out?
Yeah. So Lisa K is asking, could the gel be placed on mom's breast and the infant suck? Have you ever studied that effectiveness, or has anybody looked at that? Or is it essential that you place it in the buccal mucosa?
Yeah, I would not recommend putting it on the mom's breast because that would have the glucose gel being digested. When it's placed in the buccal cavity, on the buccal mucosa, it actually is absorbed into the bloodstream at a rate very close to an IV rate. So it's much quicker to the bloodstream if you do the massaging into the buccal mucosa. You do not, I know at first, when we first started doing it, the syringe, I would see nurses putting the syringe in the baby's mouth, and the babies were almost sucking it down. We don't want to feed the baby the gel. What we want to do is have it get into their bloodstream very quickly. Okay.
That makes
I'm seeing these answers, but okay, go ahead.
Yeah. Does your hospital compound their own gel? They're having troubles with quality products. So we know there's a lot out there for adults that have, say, dyes or other preservatives and additives. Can you speak to that?
We do not compound our own gel. We currently are using one of the adult doses. We had this already in our formulary, and unfortunately it does have flavoring and some preservatives, but if you compare what our treatment pretty much before that was formula, and if you compare the ingredients of formula to the ingredients that are in the glucose gel that is for the adults, there's no comparison. So we do use that, and I know that there's in the works there is a baby-sized glucose gel that's coming out, so that'll be great when that happens.
Awesome. So someone's asking kind of along those same lines, what else is in the dextrose gel? So she's saying we've used a dextrose polymer. Is that the same?
I'm not sure what a dextrose polymer is, but the important thing to look at is if it's 40% dextrose. So yeah, I'm sorry,
I don't. Typically the other 60% water, or what's like what makes up the rest of it?
Right. No, what's in the dextrose gel is the 40% is the concentration, but it's not that it's 40% and there's 60% something else. It's the concentration of dextrose. I'm not sure if I can explain this right, but it's not that there's 60% other stuff in there. It's the concentration of like if you had medication of of 1 milligram or 2 milligrams. It doesn't mean that there's other things. But in the dextrose gel, I don't think I have one handy, but there is a small, very tiny amount of preservatives in there, and then there's it's in a base of, I can't remember what right now. I'm sorry. I can follow up with whoever wants to email me that question. I can follow up on that and look into what the polymer is.
Okay. There's somebody, Andrea is saying, thank you for your work. Glucose gel is very important. My question's regarding the second variable that I feel is important, which is feeding. How do you establish and influence the culture of feeding in your hospital? Willingness to exclusively breastfeed, those kinds of things. Have you found that these go hand in hand? Do you have any opinion or comment about that?
Yes. Well, prior to this, prior to using glucose gel, every baby at risk ended up having formula. That was every baby with low glucose levels got formula. And now we have about the same rate of infants who receive the gel that exclusively breastfeed as we do exclusively breastfeed in the other population. So our numbers are not stellar for our whole population. I would say that we're maybe at about 60% exclusive breastfeeding. We start out with many with the intention, and but often there's infants that get 1 or 2 bottles of formula while they're here, which we do think is very important to decrease that and to educate people on the issues with formula in terms of the microbiome and the gut and how long that can make a change. So we really try to, without being too pushy with the parents, we really support exclusive breastfeeding. And the gel really helps a lot. And we do have many infants who are able to exclusively breastfeed because of the gel.
Great. Someone said they missed the very, very beginning. Can you just assure them that for the recording's sake that you just did discuss the long-term complications of infants with hypoglycemia at the beginning, or do you have any additional stats you'd like to share on that?
There's really, I have nothing more to say than what those questions are probably answered.
Okay,
the long-term complications for this transitional neonatal hypoglycemia, it resolves on its own, and if we weren't studying this, we probably would. If we didn't have this routine of doing the heel sticks on infants at these risks, we probably would never even know. And years ago, they didn't do testing, and there's not any clear evidence that asymptomatic infants have any kind of long-term sequelae from that.
Great. So kind of going with that, how many doses would be the maximum before you feel like you have to transition the baby to the NICU or to other levels
Sure, that's
of care?
a good question. And that is in the algorithm that the first one that was shown, which is the one that we're using, we have kind of 3 strikes, you're out. So the first, if an infant needs a 3rd dose of gel, so after the 2nd dose of gel, if the infant becomes hypoglycemic again, that is when the pediatrician or a NICU consult is requested. And if the numbers are very, very close to the threshold, then sometimes they'll get that 3rd dose of gel and still stay in the mother-baby area. Occasionally they'll get a 4th dose of gel, but for the most part, the infants will just get a 3rd gel and then go to NICU then.
I'm not quite sure where that feedback was coming from, but
Oh, okay.
Sounds like it went away. So maybe kind of going along with that, have you heard of any NICUs that are using glucose gel instead of the first line of going straight to IV, or are you finding that more, or do you know of any NICUs who are doing this treatment in the NICU?
In our NICU, they would give 1 dose of gel. If they had a baby, and I think everybody is different in terms of what happens when their infants go to NICU, but at our hospital, any infant that's under 35 weeks starts in NICU, and then if they are doing well, then they come back to their moms. So
Okay.
if those babies that are 34 weeks, 34 to 35, if they are in NICU and they don't have any other issues and don't need an IV for any other reason, and the only thing they have is low blood glucose, they will give them 1 dose of gel. And if it doesn't resolve after that, then they do the IV. So yes,
Great.
it is being used some in NICUs, but it's very sporadic. And yeah, so.
And in your experience, have you at your hospital or other places allowed the moms to be the one to offer the gel?
Oh, I think it's a great idea. We try to, my recommendation is to administer the gel in the mom's room. And actually, there's no reason why the mom couldn't, once a nurse draws up the proper amount, put it on the mom's finger and have her massage it in. That's really actually, hey, genius. That's a great idea. It's a new idea. I love it. Yeah, yeah.
Not sure if there's any evidence around this, but someone has a question around donor breast milk and knowing if donor breast milk or colostrum has any better response to infant blood glucose, like maybe from a percentage of macronutrients, I guess.
There was just a study published in the Nursing for Women's Health, and the people were, I think it's the same authors that were at AWAN speaking about this last year in June of this year. And I don't know that it's better. It's different. Donor milk is an excellent option also. It certainly is not available in many places, and it's extremely expensive. We are looking at some sort of protocol to utilize donor milk for infants that, for instance, will probably be using it initially for infants on phototherapy who need more than what they're getting from their moms. I love the idea of donor milk, and it's just becoming easier to get. There's shelf-stable donor milk out there, which has very mixed reviews, but I think donor milk would also work. It doesn't have the immediate. It doesn't have a high percentage of sugar, so it may be that that it could be used in combination with glucose gel. So you would give the gel, and then if the baby's not suckling very well, it could have a few mLs of the donor milk. So I don't think it's an either or, and I don't think there's a better, but it is very expensive. Glucose gel for a dose, even using the tube that's for adults, it's about $3 a tube. So it's very inexpensive when you compare that to a NICU stay of maybe $5,000 a night, which is why we came up with such a huge savings. And I do see that somebody was asking how many births with the $3 million in healthcare savings, and that's about 12,000 deliveries across our system.
Great.
If you add in all the hospitals.
So Diana just asked a question kind of dovetailing with that health savings around they've implemented in their well baby nursery the use of glucose, and they've seen a reduction, but they still have 2 or 3 sugar babies a month. Is this what should be expected? Is this out of the norm? I think it kind of depends on what your numbers are, right? So like if you went from 150 to 2, sure. But do you have any, like what's the outlier that they should be looking for maybe in kind of a stricter percentage?
Well, I think it certainly depends on your population, and I would more look at if to what you expect. If those 2 or 3 babies are going to NICU and then staying in NICU for a week or two at a time after their birth, then they really probably needed to be in NICU. The babies that were, there are some babies that have issues with blood sugar and metabolic problems for sure. And when I look now, it used to be that we would do a NICU transfer, and the baby, this is before we used gel, the infant would get down to NICU, and they would say, this baby's not hypoglycemic. It already would heal on the, they already were, the blood glucose, right. But now when I look at the length of stay for infants in NICU, it's maybe a week or 10 days. So these infants clearly needed, they're not resolving after a dose or two of gel, and even not resolving after a week on IV dextrose. So they just need, you know, further examination. So I would look to the 2 or 3 babies a month that you have and see how long are they in NICU, and is there some way that you're missing actually, maybe they're not, maybe the nurses are not administering the gel properly, so you could show them this little video clip maybe, and making sure that the infants get breast milk, or if they're formula fed, get at least 15 mLs of formula after the gel. But yeah, I would do like a little deeper dive onto those babies to see how long they're actually in NICU once they go, rather than saying we should only, yeah, you don't want to look at a number. You want to look at the babies.
Yeah. One quick question around gestational age. Can you remind everyone what's the youngest you use this treatment on?
We, in our 34 weeks, I will answer that as 34 weeks. 34 to 35 weeks, we use that in, that baby would be in NICU. So 35 and above, we use that. That's what we do on our unit, and that's pretty typical, because I don't think in most places that the babies under 35 weeks are usually in NICU. Right. So once they're on the floor, but for sure the preterm, anybody under 37 weeks will get it, and then for those other.
The other question that just popped up is they're having some postnatal ward midwives who are worried about high concentrations making babies sleepy and making it more difficult to establish breastfeeding. Is this a myth, or have you seen this happen?
This is a really good question, and I wish I had brought this up in my presentation, but you give me a chance to bring this up. We have not seen that. We've not seen that at all. And all of the glucose levels, I've never seen a high glucose level from after the gel. In fact, we've never gone above 100 milligrams per deciliter after using gel. But when I look at the babies in NICU, once they get the IV, then their sugars get really high, which can also be a problem. Hyperglycemia can also cause problems for infants. So I feel after giving this to 1,300 babies and never having a baby go even up to above 100 milligrams per deciliter, we're not creating hyperglycemia. Excellent. So, and I haven't seen the babies be tired from that. They usually go right to breast.
Someone's asking if glucose gel is considered an exclusion in the core measures for Joint Commission on exclusion. Okay, exclusive breastfeeding.
Yes, it is.
Okay, great. And then there's a couple people asking just about implementation, but I'm thinking maybe your shared algorithm from the slides will help them with that. You know, what do they do to push the needle in their unit if they want to do that? And then some very specific things around Louisiana. I don't know if you know of implementations happening there.
I do not know of anything happening in Louisiana. I am going to Oklahoma in November, but I would be happy to come to Louisiana if there was a group that was interested in hearing more about this or setting up a webinar. And in terms of your prior question about implementation, I am happy to share. If you email in the beginning of the thing, it shows my email. If you email me, I will send any teaching strategies and like a sample order set and anything that you would need to get started.
That's so generous. And then the final question is around pain relief. And is glucose gel being used for pain relief instead of, I'm guessing, liquid sucrose?
Yeah, no, it's really it's two different things. It might have some pain relieving. It hasn't been studied, but the concentration of the sweeties and those types of things is it's I think more at 25%. So it's really it's different, and it's so I don't know. It's an interesting question. I haven't seen anything about pain relief with a glucose gel.
So I think that's
maybe the next study.
Yeah, people should just remember that sucrose, remember the molecule sucrose is 50% glucose and 50% fructose. And fructose makes that molecule much more sweet, which then actually activates the endocannabinoid system, which is going to release that opioid response. That's why sucrose works. It's only 24% of sucrose, which is only half of that is actually the dextrose, or the glucose part of that. So that's really only 12%. So it's a really much, much smaller dose. So it's not effective to use those products really as a treatment either. So that's why you really need those higher concentrations gels that are made for that. So just remember the chemistry of sucrose, that it's 50% dextrose, 50% sucrose, and that will give your answer to your team who are thinking about that. So glucose isn't sweet, so it's not gonna hit the receptors in the tongue the same. It's not gonna cause that release of the endorphins.
Oh, thank you.
Yeah,
Good answer.
Perfect. Well,
that was the last of them.
Yeah, lots of great questions. Thank you all so much. And thank you, Catherine, for your great answers. And now I want to let people know that in order to receive your free CE, you will need to fill out the webinar evaluation. So in the chat area, Kathy will post a link to the evaluation. If you're watching the recording, please go back to the email you received with the link to the recording and click on the link to the evaluation form. You will receive an email with a PDF of your CE certificate within 24 hours after you fill out the evaluation. Be sure to check your spam if you don't receive the email within 24 hours. Now, if you're watching live and you don't have time to fill out the evaluation right now, or your hospital has blocked access, you will receive an email within a day or so with a link to the evaluation as well as a link to the recording. And one quick thing, if you're viewing as a group, you must each log on to the evaluation form in order to get your own CE. We hope you'll like us on Facebook or LinkedIn to be the first to find out about what's new at Dandelion Medical. And conveniently, we are just getting ready to launch an exciting new product, which is called Sweet Cheeks, and it's a 40% glucose gel in an oral syringe. We are really excited about the product. It meets all the requirements that Catherine stated. There is one baby-friendly preservative in it, but it has no artificial ingredients, nothing that's bad for the baby. The 40% does get it. The gel becomes 40% because it's mixed with USP purified water. So that's where you get the 40% concentration. We are really excited about this product, and it should be out within the next couple of months. So you'll have an opportunity in the evaluation to indicate if you'd like to receive more information or samples of the Sweet Cheeks. So be sure to check that box if you'd like to get them. We hope you'll visit the Dandelion Medical website to hear more about our next webinar on November 12th. And you can also find links to the recordings of our previous 3 years of webinars that are all still active and available for continuing education credits. So thank you all for listening. Many thanks again to Catherine for another great Dandelion webinar. And we look forward to seeing you in November.